it's Olivia. Welcome back to your endocrinology section. In this chapter, we'll be talking about your parathyroids and calcium homeostasis. So first, we'll talk about the location and the function of your parathyroid glands. Then we'll talk about vitamin D deficiency. Vitamin D, of course, is very important for calcium homeostasis. We'll talk about hypoparathyroidism, hyperparathyroidism, and then finally, familial hypocalciuric hypercalcemia. So let's get started. Now, in this video, we're going to be talking about our parathyroid location and function. So diving right in here, our parathyroid glands are going to be these two pairs of small oval-shaped glands on the posterior aspect of the thyroid. If you look over here, you can see these purple dots on the posterior aspect of our thyroid gland. Those are going to be our parathyroids. First, we have our superior parathyroids. Those are going to come from the fourth pharyngeal pouch. And then right below them, you have our inferior parathyroids, and those are derived from the third pharyngeal pouch. So I always think count up. So the top or superior parathyroids are going to be derived from that fourth pharyngeal pouch, whereas the inferior parathyroids are derived from the third pharyngeal pouch. And the main job of your parathyroid glands and parathyroid hormone is to maintain calcium homeostasis. So why do we need calcium homeostasis? Why is it important that we have just the right amount of calcium in our body? Well, calcium, if you remember, is responsible for muscle contraction. So when calcium is released from the sarcoplasmic reticulum, that is when we can initiate muscle contraction. Similarly, calcium is important for cardiac depolarization, so that membrane potential in our cardiac myocytes is very calcium dependent. Calcium is also important for nerve function. It helps with the release of certain neurotransmitters, and then additionally just membrane potential in general. As a charged particle, it is going to be responsible for some of that electrochemical gradient. So calcium has a lot of roles in the body, and that is why if we have hypercalcemia, let's say we have too much calcium in our body, we can see symptoms across a ton of different organ systems. For example, calcium oxalate kidney stones. And a quick note here, you can also have calcium phosphate kidney stones. What's happening here is when you have too much calcium in the blood, that calcium can bind to other things like oxalate or phosphate, precipitate out of solution, and then as it precipitates out of solution, it creates a solid, which will of course be that kidney stone. So you have hypercalcemia can lead to kidney stones. Additionally, constipation, it can kind of slow down your gut. Bone pain, that'll make more sense once we go through this pathway, as well as different arrhythmias. And the mnemonic you might have heard to remember all the symptoms of hypercalcemia is stones, bones, thrones, and psychiatric overtones. So the stones would be the kidney stones, the bones would be the bone pain, the thrones would be constipation, because of course you are sitting on the throne or the toilet and unable to go, and then the psychiatric overtones would refer to psychosis. On the other hand, if you have hypocalcemia, so too little calcium, that is going to present with a whole different set of symptoms. So first, you may have tetany or rigidity of those muscles. You may have a prolonged QT interval, and as you remember, a prolonged QT interval can be very dangerous. It can lead to torsades, which of course it can be life-threatening. You can have seizures with hypocalcemia. And then these two very specific signs they love to test you on. First, we have chopstick sign, which is essentially when you tap someone's cheek kind of right by their ear, and then you see twitching or prolonged twitching of their face. That is a sign of hypocalcemia. And Trousseau's sign is when you put a blood pressure cuff on someone and you tighten it up really tight, and then you see kind of the shaking or tremor of their hand. That's another sign of hypocalcemia that could definitely show up in a board's question. So we've talked about why it's important to have just the right amount of calcium in your body, but how do we maintain that? Well, it's through this pathway. So first over here, let's look at our parathyroid glands. Remember, we have our superior and our inferior parathyroid glands on the back of our thyroid, and they're going to respond and release parathyroid hormone anytime we have decreased calcium and increased phosphorus. And it's primarily concerned with the decreased calcium, although the increased phosphorus can also trigger the release of parathyroid hormone as well. So when we have decreased calcium, we don't have enough calcium in our body, our parathyroid glands are going to be stimulated and they are going to release parathyroid hormone. Parathyroid hormone acts directly at our kidneys and at our bones. But first, let's talk about our kidneys, because they're kind of the central player in this pathway, and they are going to control the net outcome of this pathway, which is why I have given them this little crown here to help you remember that the kidney is the king of our calcium and parathyroid pathway. So when parathyroid hormone acts directly on our kidney, it is going to stimulate calcium absorption and phosphorus excretion. So we're going to be saving that calcium, which will lead to a net increase in calcium, and then we are going to be getting rid of that phosphorus, which leads to a net decrease in phosphorus. And I've included your high yield button right here because it's really high yield for you to remember that the net outcome of this entire system, regardless of what anything else is doing, is going to be congruent with what the kidneys are doing. That is why the kidney is the king of this pathway. So net takeaway here is that when parathyroid hormone is released, we are going to get a net increase in calcium in the blood and decrease phosphorus in the blood. But in addition to their own job of saving that calcium and excreting that phosphorus, the kidneys also have another important role in this pathway, and that is that they contain the special enzyme 1-alpha hydroxylase, and this enzyme 1-alpha hydroxylase is converting vitamin D into its active form. So vitamin D kind of floats around in your blood. It may not be in the active form, but this enzyme in the kidneys, 1-alpha hydroxylase, converts vitamin D into 1,25 dihydroxyvitamin D, which is going to be the active form of vitamin D. This active form then can go to the bones, and at the bones it will stimulate bone breakdown, and as the bones break down, or we have bone resorption as it's called, we'll get calcium and phosphorus release. So we'll see increased calcium and increased phosphorus. Now we see an increasing level of phosphorus here because we are releasing it in conjunction with calcium from our bones, but remember all of that phosphorus is going to be filtered out by the kidneys and excreted by the kidneys, so we're still going to have that net decrease in phosphorus as a result of this pathway, which is really important for you guys to keep in mind. Similarly, in the gut over here, our active form of vitamin D, that 125 dihydroxyvitamin D, travels to our gut, and we are going to get increased calcium and phosphorus absorption. Okay, so we have increased calcium and phosphorus absorption. That'll lead to increased levels of calcium, which is exactly what we want to see. And then additionally, you'll have increased phosphorus here, but just like we had the increased phosphorus with our bone resorption, that phosphorus that we absorb is just going to get filtered out by the kidneys. So again, the net impact of this pathway will be increased calcium and decreased phosphorus, even though we have an increase in phosphorus through the absorption in the gut. Now there's one final piece of this pathway that I want to talk about, and that is the role of fibroblast growth factor 23. So when we have increased phosphorus, our phosphorus level gets too high, that is going to stimulate the bone to release fibroblast growth factor 23, and fibroblast growth factor 23 is going to travel to the kidneys because the kidneys are the king, and it is going to increase phosphorus excretion, so increase the kidneys' role in excreting phosphorus, which of course will decrease the overall phosphorus, which is what we want to do because we're responding to increased phosphorus. It also will kind of shut down the rest of this pathway. So it's going to inhibit our 1-alpha hydroxylase enzyme to stop the production of dihydroxyvitamin D. We are also going to inhibit our parathyroid glands. We are going to stop the production of parathyroid hormone. So fibroblast growth factor 23 is an inhibitory molecule that is basically going to shut this pathway down with the exception of increasing phosphorus excretion in the kidney. So that was a general overview of this pathway. Let's get into a little bit more detail here. So first we talked about parathyroid hormone. Parathyroid hormone, of course, is a peptide hormone. It was released in response to decreased calcium. It is going to be secreted by our chief cells in the parathyroid. So it is our chief cells, those specific cells in our parathyroid gland, that are releasing parathyroid hormone. Parathyroid hormone travels to bone, where we already talked about the increase in calcium release as well as the increase in phosphate release. And then zooming in on our bone, a closer look at what's happening here is first we have our osteoblasts, right? And our osteoblasts get activated first by parathyroid hormone. I always remember B for blasts. Blasts are the builders, so these are the builders of bone that make new bone. Our osteoblasts secrete RINK ligand, and RINK ligand is then going to go and bind on our osteoclasts. So if osteoblasts are our builders of new bone, osteoclasts are going to cause our bone to crumble. So clasts crumble bone and release more calcium. That is what the C stands for in my mind at least. And when RINK ligand binds on our osteoclasts, they then become active, and those are going to be the ones that actually consume our bone, do this bone resorption, and through consuming this bone, release the calcium and the phosphate into the system. So remember that our osteoblasts are the ones that are going to get activated first. Those are then going to secrete RINK ligand, and then our osteoclasts, of course, are going to be the ones that are degrading this bone. Parathyroid hormone also traveled to our kidneys. Remember, the king of this system. And in the kidneys first, we are stimulating calcium absorption and phosphate excretion, the net goal of this entire pathway. And then additionally, parathyroid hormone stimulates 1-alpha hydroxylase activity, remember, in our kidneys. And 1-alpha hydroxylase is going to be that enzyme that is forming the active form of vitamin D. So 125 dihydroxyvitamin D has a couple different names. It is called calcitriol. This is the active form of vitamin D. It's also sometimes just called the active form of vitamin D, or vitamin D3. But whatever you call it, 125 dihydroxyvitamin D has several important functions in this pathway. Increased calcitriol first can travel to your gut. So once it travels to your gut, it is going to stimulate stimulate calcium and phosphate absorption. It also is going to travel to your bone, and like we talked about with your bone over here, it is going to increase calcium release and phosphate release as we are stimulating those osteoblasts to release rank ligand to bind to osteoclasts that are going to crumble our bone, release that calcium, and release that phosphate back into our system. And then finally, we talked about fibroblast growth factor 23, which is going to be primarily responsible for phosphorus homeostasis. We've been talking about calcium homeostasis, but phosphorus is what is going to be triggering the release of fibroblast growth factor 23. Fibroblast growth factor 23 is secreted by osteocytes and osteoblasts, and osteocytes are kind of the same thing as osteoblasts. They are a more mature form of the osteoblast that is embedded in the osteoid, but I included them both here on your slide for completeness. Increased phosphorus or increased calcitriol is going to stimulate the release of fibroblast growth factor 23. The net effect of FGF23 is going to be decreased calcitriol, right, because we decrease the activity of 1-alpha hydroxylase, as well as increased phosphate excretion. We are increasing that phosphate excretion at the kidney, and decreased parathyroid hormone. We are decreasing the parathyroid gland's activity and secretion of PTH, so we are going to have low levels of parathyroid hormone as well. And then the last molecule that I want to mention is calcitonin. And calcitonin is secreted by our parafollicular C cells. So remember, our chief cells make parathyroid hormone, and then calcitonin is secreted by the parafollicular C cells, and it kind of opposes the actions of parathyroid hormone. So it's fair to think of it kind of as the opposite of PTH. It will decrease our osteoclast activity. Remember, our osteoclasts are remodeling this bone, releasing calcium. It will also decrease renal calcium resorption. So that is directly the opposite of what parathyroid hormone does, and that's why it's kind of fair to think of calcitonin as doing the opposite of what parathyroid hormone does. Now, that's a lot of information, but if there's three things that I really want you to take away from this pathway, what I want you to remember is the ABCs of our parathyroid hormone and the calcium pathway. So the A stands for 1-alpha hydroxylase. That is the most important enzyme to remember that is making our active form of vitamin D, 1,25-dihydroxyvitamin D. The B stands for bone and bowel. So that is where our 1,25-dihydroxyvitamin D is going to go. In the bowel, it's going to stimulate the absorption of calcium and phosphorus, and in the bone, we are going to stimulate that bone remodeling. First, our osteoblasts are activated, so that's why B comes before C, because our blasts are going to activate our osteoclasts, and then once our osteoclasts are activated, those are going to destroy our bone and release our calcium into circulation. The net effect of this pathway is increased calcium and decreased phosphorus, and the excretion of phosphorus is mediated by the kidneys here. Now, how would they ask you about this in a board style question? Well, something they might ask is, a 14-year-old girl presents for 3 months of increased joint and muscle tenderness. She has a history of Crohn's disease and currently takes 6-mercaptopurine to control her frequent flares. DEXA scan reveals evidence of decreased bone density. What would be the expected laboratory values for parathyroid hormone, 1,25-dihydroxyvitamin D, and calcium? Okay, so this patient has Crohn's disease. She is presenting with this decreased bone density and tenderness. It really sounds like she has a vitamin D deficiency. And a vitamin D deficiency can be commonly seen in anyone with malabsorption, especially Crohn's patients, anyone who has problems absorbing their fat-soluble vitamins, so patients with cystic fibrosis or patients with celiac disease. But we have this vitamin D deficiency, which means that we know that we're not going to have as much of our vitamin D floating around, and certainly not as much of our active form of vitamin D, 1,25-dihydroxyvitamin D. Because we also know that our vitamin D is going to be absorbed with calcium, we know that we're contending with kind of a lower calcium state. This is going to mean that our parathyroid hormone is stimulated, so that would certainly be increased. And then whether or not our parathyroid hormone is able to get enough calcium out of our bones or stimulate enough calcium absorption in our gut, even though we know we're not absorbing vitamin D very well, which is going to decrease the amount of calcium we can absorb, calcium will either be normal or decreased. It kind of just depends on how good of a job parathyroid hormone is able to do with the reality that we don't have enough vitamin D in our system. Now, I hope this video was helpful and made you more confident with calcium homeostasis, and I'll see you next time.